All right, hello and welcome. Today, we're going to be medical detectives. We're diving into a case that starts with some pretty common, maybe even harmless-seeming clues, but leads us to a culprit that's, well, pretty surprising. Let's get right into it.
Okay, so let me ask you this. Have you ever noticed a nagging cough that seems to show up right after you've finished a meal? Or maybe you're dealing with bad breath that just won't go away no matter what you try. These things might just seem like little annoyances, right? But what if they're actually clues pointing to something much deeper? What on earth could be causing that?
So our investigation really kicks off here. We're on the hunt for the real source of these symptoms. And the answer? Well, it's now what most people would guess. It's actually a structural problem, a kind of unexpected feature in our anatomy.
And here it is. This is our culprit, an esophageal diverticulum. All that really means is it's an abnormal little pouch that bulges out from the wall of the esophagus. You know, that tube that connects your throat to your stomach. This little pouch is the source of all the trouble. Now, you might think a pouch is just a pouch, but it's not that simple. To really get a handle on them, clinicians classify them in three main ways. First, pretty obviously, is by location. Is it high up, in the middle, or down low in the esophagus? Second is by their actual structure, or histology. Is it a true pouch that involves all the layers of the esophageal wall, or is it a false one, where only the inner layers have kind of poked through a weak spot? And finally, and this is key, is how they actually formed in the first place.
So how do you even spot one of these things? The real clues start showing up when that pouch gets big enough to actually trap food and saliva. And for a pouch in the upper esophagus, this creates a pretty classic list of symptoms. We're talking about things like difficulty swallowing, or even food coming back up that hasn't even hit your stomach yet. We already mentioned that nagging cough after eating, but that can get serious and lead to aspiration pneumonia. Other signs? Maybe some chest pain, losing weight without trying, or even a noticeable lump in the neck if the pouch gets really big.
And this right here, this is one of the most telltale clues of all. That persistent bad breath or halitosis, it's considered a classic sign. And it makes perfect sense, right? Old food gets stuck in that little pouch and just sits there. It's a small detail, but for a diagnosis, it's a huge clue.
But just when you think you've got it figured out, there's a twist in the case. While those upper pouches are making all sorts of noise with symptoms, the pouches in the middle and lower parts of the esophagus, they're often totally silent. They usually don't cause any symptoms at all. So if someone does have symptoms, it's a major red flag that there's probably an underlying motility disorder. Basically a problem with how the esophageal muscles are working to move food down.
And that brings us to the real heart of the mystery. How do these pouches even happen? Well, it all boils down to a battle of forces. It's this intense struggle between forces pushing from the inside versus forces pulling from the outside.
Okay, let's break this down because it's actually pretty fascinating. On one side, you've got what's called pulsion, which is basically a push. This happens when there's way too much pressure inside the esophagus. Maybe a sphincter muscle isn't relaxing like it should. That pressure forces the inner lining out through a weak spot in the wall, creating what we call a false diverticulum. Then, on the other side, you've got traction, which is a pull. This is caused by something on the outside, like inflammation or scarring from an infection, that literally pulls the entire esophagus wall outward, creating a true diverticulum. Push versus pull. Simple as that. Okay, so we've got our clues, and we understand the mechanics of how these pouches might form. So how do doctors actually track one down and get a final definitive diagnosis? Let's follow them on the diagnostic journey.
It's usually a pretty logical three-step process. The investigation almost always starts with something called a barium swallow. The patient drinks this chalky liquid that lights up on an X-ray, making the pouch super easy to see. After that, next up is often an endoscopy, where they use a tiny camera to go look inside the pouch itself, just to make sure there's nothing else hiding in there, like cancer. And finally, especially if we suspect a middle or lower pouch, they'll do a manometry test. This measures all the pressures and muscle movements in the esophagus to find any of those hidden motility problems we talked about.
And I've got to stress this because it's absolutely critical. For those sneaky, silent, middle or lower pouches, those last two tests, the endoscopy and the manometry, they are required for every single patient. Even if they feel perfectly fine and have zero symptoms, the risk of missing a serious underlying disorder is just too high to skip. So we've found the culprit, we've confirmed it's there, case closed, right? Not quite. Now comes the final act of our mystery, actually solving the problem. And this can mean anything from just keeping an eye on it to heading into surgery.
The decision-making here is actually really logical, as you can see. It basically comes down to two questions. First, is the pouch causing any symptoms? And second, how big is it?
If it's small, we're talking less than 2 centimeters, and it's not bothering the person, the recommendation is usually just to observe it. But if it is causing symptoms, or if it's 2 centimeters or bigger, then surgery to remove the pouch is usually the way to go.
And we have to add one last, really crucial piece to this puzzle. Remember how those middle and lower pouches are often caused by those motility disorders? Well, you can't just remove the pouch and call it a day. You have to treat the underlying condition that caused that push or pull in the first place. If you don't, you haven't truly solved the problem.
All right, so as we close the file on this case, let's do a quick debrief. What are the real risks if this thing is left untreated, and what are the absolute key takeaways you should remember from all this?
So why is getting a diagnosis so important? Well, the stakes can be pretty high. The most common complication, by far, is aspiration pneumonia. That's when food and saliva from the pouch spills over into the lungs. It's rare, but much more severe things can happen, like a tear in the esophagus, or even the development of esophageal cancer. So, yeah, you definitely want to get it checked out.
So here's the bottom line. An esophageal diverticulum is just an abnormal pouch in the esophagus. It's formed either by being pushed out from the inside or pulled out from the outside. The first step to finding it is usually a barium swallow, and what you do about it all depends on its size and whether it's causing any trouble. And with that, our case is officially closed.
And that just leaves us with one last thing to think about. We just saw how something as simple as a cough or bad breath can point to a very specific, hidden structural problem. It really makes you wonder, doesn't it? What other common symptoms that we tend to just brush off could actually be clues pointing to something else entirely. Something to chew on. Thanks for joining me on this one.